Good afternoon. I'm Dr. Julie Steck, a psychologist at Children's Resource Group. I know the name on your screen says Angela Middleton. She's our practice administrator who sets this all up, and we don't know how to take her name off of it. By the way, Angela's on maternity leave, having just had a little girl, and we miss her greatly. I want to thank you all for attending today's webinar on attention deficit hyperactivity disorder in females, underdiagnosed and misunderstood. For those of you not familiar with Children's Resource Group, we are a multi-specialty behavioral health practice that has just celebrated its 25th anniversary. In that time, we have seen many of our patients grow, change, and evolve. And in that time, CRG has grown, changed, and evolved. We now see children, adolescents, and adults, and provide a wide array of psychiatric, psychological, and educational services. In the 25 years we've been in existence, we've also seen the field of mental health grow, change, and evolve. And no area has evolved more than the area of attention deficit hyperactivity disorder. It is the most studied and researched area of child mental health, and I am proud to be able to represent our current understanding of this disorder today. The focus will be primarily on females with ADHD, as this is a group that is often overlooked, misunderstood, and underdiagnosed. I'm now going to turn off my camera so that you can focus on the presentation. I will be taking questions towards the end of the presentation. You may enter those under the question, where you see question on your dashboard. You may also download a PDF file of this PowerPoint presentation under handouts. So with no further ado, I will turn off my webcam and start the presentation. First, we're going to start with a poll. On your screen, you should be able to indicate what your interest in this topic is. Are you participating as a parent, a teacher, educator, an individual with ADHD, or a mental health professional? By the way, if you are attending as a mental health professional, this presentation will qualify for Category 2 continuing education. You will not need any copy of your attendance, but it will qualify for Category 2 CEs. So I'm going to close the poll here in just a moment. It looks like of those attending, 53% are parents, 7% are teacher educators, 7% are individuals with ADHD, and 33% are mental health professionals. So we're going to start with two case studies. And just so you are clear, these individuals are not real people. I have changed all the information so they do not represent any one individual. And in fact, these case studies are very easy to develop because they are so typical of what we see in our office. So let's talk about Callie. Callie is an 8-year-old female currently in 2nd grade. She was initially seen for fears of getting sick and vomiting. She has frequent headaches and stomach aches on school days. She has emotional meltdowns at home, but is very well behaved at school. However, she gets little work done during the school day. Homework time results in arguments. She makes friends easily, but she does not sustain her friendships. She gravitates to playing with boys and or other girls who are active and impulsive. She sucks her thumb when watching videos and falling asleep. but she has trouble falling asleep at night. She needs much prompting to get ready for school or bed. She lies about little things like, did you brush your teeth? Did you do your homework? She talks constantly, but does not always get to the point, and she does not entertain herself well. Stephanie, also not a real person, is a 38-year-old female whose son had been diagnosed with ADHD. She's the mother of 2 children who remains at home. She felt that this would allow her to focus on her children, but with each child, she had more difficulty with organization and home management. She's been diagnosed and treated for anxiety and depression for years. She graduated from college, but she always thought of herself as dumb. She's overweight and reported that she is always dieting. She struggles with completing daily tasks such as cleaning and shopping. She's very social, but she has a hard time saying no. She procrastinates and then feels stressed and overwhelmed. She stays up late at night and can get lost on the internet. She struggles with waking up in the morning. And Stephanie feels that she is constantly disappointing others by not completing what she expects of herself. So if you are a professional who is working with children or working with female adults, understanding ADHD can help us provide a framework for understanding the past and a path for improved future. We know that ADHD is comorbid with mood disorders, eating disorders, primarily bulimia, anxiety disorders, substance abuse, cigarette smoking, academic underachievement, poor self-esteem, suicidal thinking, and self-injurious behaviors. So having ADHD puts an individual at high risk for other mental health conditions. I am sorry, my cursor has just gone out. There we go. So what are the objectives for today? First, we want to help you recognize the symptoms of ADHD in females across the lifespan. We want you to be able to list 4 long-term consequences of untreated ADHD in females. Identify other mental health conditions which often coexist with ADHD in females, and list 4 essential components of a treatment plan for ADHD. So what is ADHD? First of all, ADHD is underdiagnosed and undertreated. Who are diagnosed with ADHD are treated. ADHD is undertreated. Only a small percentage are treated, and treatment is always discontinued. ADHD is a developmental disorder. It's diagnosed relative to an age group, and that means that in that age group, the individual is having more difficulty than all but 7 to 10% of peers. ADHD results in a 30% delay in acquisition of self-regulation and self-control. And ADHD persists throughout the lifespan in at least 60% and more likely up to 90% of individuals. ADHD is not an input disorder. It's a disorder of performance, not skill. Individuals with ADHD have the skills to do what is needed, but they don't do it when they need to do it. It's not a matter of not knowing what to do, but doing what you know when you need to do it. It's a disorder of responding more to stimuli than others do. ADHD is poor persistence of responding and impaired resistance to distraction. It is difficulty with task re-engagement once there's a disruption. We know that ADHD causes impaired motor inhibition and poor sustained inhibition. So people with ADHD are more impulsive, and if they do control their impulses, they have trouble maintaining inhibition. They have excessive and often off-task motor and verbal behavior. And they have excessive restlessness that becomes more internal with age. This means that it is harder to see ADHD as a person gets older because it's happening within the individual. So we're going to go through the symptoms for adult ADHD. And this symptom checklist was developed by Barkley. And what he found through research is that there are 9 primary symptoms we need to look at. And the first and most prevalent symptom identified by adults with ADHD is, I am often easily distracted by external stimuli. Second, I often make mistakes impulsively. And I often have difficulty stopping activities or behavior when I should. Adults with ADHD identify, I often start a project or task without reading or listening to directions carefully. I often show poor follow-through on promises or commitments I make to others. I often have trouble doing things in their proper order or sequence. And I am often more likely to drive a motor vehicle much faster than others. And finally, I often have difficulty sustaining attention in tasks or play recreation activities. I often have difficulty organizing tasks and activities. So from their study, Barkley, Murphy, and Fisher identified that if an individual has 4 of the first 7 symptoms or 6 of the 9 symptoms, they likely meet criteria and should be further evaluated for ADHD. Adult ADHD is not a benign disorder. It creates impairments in every domain that we have examined so far in this study. Russell Barkley is the preeminent researcher in the field of ADHD, and he is now retired, but he has posted all of his major lectures online. They can be obtained on YouTube for us to review and learn from. So Dr. Barkley researched and studied ADHD for 40 years, and I rely heavily on his information in helping me know how to diagnose and treat individuals with ADHD. Dr. Barkley's research indicated that the domains of impairment in individuals with ADHD include education, occupation, social interactions, community and legal aspects of life, and dating and marital aspects of life, as well as driving, leisure, daily responsibilities, and financial. We're going to focus a minute on educational impact, because especially when we are dealing with children, adolescents, and young adults, we see a significant impact educationally. Will have reduced productivity. So they do not produce as much work, and they do not produce the quality of work that others their age do. Those with ADHD have a high rate of high school dropout. So we know that they are more likely to drop out of high school, and they have greatly increased retention in grades or repeating grades. The rate of suspensions are greatly increased, and I think we would find that this rate is even higher in 2019 than it was back in the early 2000s when Dr. Barkley conducted his research. And expulsions are greatly increased in individuals with ADHD. What we know is that fewer individuals enter college. So the number of people with ADHD entering college, depending on the study, is from between 22% lower than the general population to 77% lower. We also see lower college graduation rates. At CRG, we work with a number of individuals with ADHD who start college but struggle with continuing, often needing time out to reorganize, find out their passion and their direction, and then restart. And those with ADHD have significantly lower GPAs than the general population. We know that there's significant occupational impact on individuals with ADHD. They often enter the workforce at an unskilled or only semi-skilled level. There's higher rates of unemployment, 22% of those with ADHD versus 7% in the general population. Now that was based on research in the early 2000s. They're more likely to be fired than those without ADHD. They change jobs more often, and they have lower work performance ratings. Those with ADHD use more sick days, they file more health insurance claims, and by their 30s, a large number of them are self-employed. Sometimes this works for them, but usually they need to have a good administrative support system. Those with ADHD have fewer close friends. They have shorter duration of relationships. They spend more time watching TV, talking on the phone, being on the internet, and socializing. They spend less time reading, studying, and exercising. And they have greater parenting stress. So if an individual with ADHD is a parent, it causes more stress, and we see more maternal depression in individuals with ADHD. We know that there is less sharing and turn-taking and cooperation in children, more conflict with siblings. Those with ADHD have increased emotional responses, and they are often intrusive with others. I know we have a lot of parents on this webinar today, and I would think that many of you will see this in your children as you interact with them. Those with ADHD are 2 times as likely to die by accident or suicide. We know that accidents and suicide are the highest cause of death in individuals in childhood, adolescence, and young adulthood, and those with ADHD are at higher risk. There's increased rate of cigarette smoking, and those with ADHD start at an earlier age. And there's a significantly higher rate of substance abuse disorder. We know that driving is greatly impacted by having ADHD and not taking your medication routinely. People with ADHD have poor steering and slower braking reactions, especially when they're not on their medication. they are much more likely to drive before they have their license. So they take cars when they don't have a license and they drive without adequate training. There are more accidents in those with ADHD and more speeding tickets. When an individual with ADHD has an accident, the cost of the accident is 2.5 times more than other traffic accidents by people without ADHD. And if they are using alcohol and driving, the impact is worse on those with ADHD than it is on those without ADHD. Those with ADHD begin their sexual activity earlier than those without ADHD. Now, this data is a little older, so I'm not sure what we would see on the age of beginning sexual activity in 2019, but I'm sure it's at least those with ADHD starting at 15 versus those without ADHD starting at the average age of 16. Those with ADHD have more sexual partners in their lifetime. And they have had more partners in the prior year. They spend less time with each partner, and they are less likely to use contraception. So those with ADHD, both male and female, tend not to, their impulsiveness leads them not to take appropriate precautions. Thus, we see a greatly increased rate of teen pregnancy in individuals with ADHD. 38% of those with ADHD, teen pregnancies are higher, 38% in those with ADHD versus 4% in those without. We know they have higher risk of sexually transmitted diseases, and they have higher risk of sexual disorders, higher rate of divorce, and childhood. However, it is not well studied in females. We know that ADHD is linked to long-term negative outcomes in males, and it's linked to significant deficits in executive function. So I'm going to see if, wait a minute. I'm going to see if I can get this video to run, but if I can't, I'm sure you all have seen the Charlie Brown comic. I'm often asked, why is there more ADHD? Well, first of all, this is a highly genetic condition, and about 80% of those with ADHD have it on an hereditary basis. Secondly, we have more premature babies survive, and the risk of ADHD goes up with the amount of prematurity and with low birth weight babies. Thirdly, ADHD is more recognized. So I think we are diagnosing it more readily and I believe more accurately. And also the increased demands of education and society probably cause increased functional impairment, where we could get by with having a little bit of ADHD back in the 60s or 70s or 80s. It's more impairing in the 21st century. So 80% of ADHD is genetic. There are multiple genes involved. And what we know is if one parent has ADHD, each child has a 30% risk of having ADHD. And if both parents have ADHD, each child has more than a 50% risk. If one child in the family has ADHD, there's a 30% chance that each biologic sibling will have it as well. So now we're going to look at two studies that have been done looking solely at females with ADHD. And I'm not going to go through all the details of the research, although I've included it here, but we will look at the implications. So in 2010, Biederman et al. At Massachusetts General Hospital conducted a study, a long-term study looking at females with ADHD. And this was an 11-year follow-up. So they had identified these females and then 11 years later followed up. 96 females with ADHD, 91 without ADHD. These are the measures that they used. This group at the age of follow-up had an average age of 22. They were primarily Caucasian and primarily intact families. What they found is that 62% still had impairing symptoms of ADHD when they reached adulthood. They were at significantly higher risks of having antisocial characteristics, mood, and anxiety disorders. They were, however, at lower risk of having antisocial personality disorders. Those are disorders that make a person at risk for having legal issues, likely to do things that might harm others. Females were at lower risk of antisocial personality disorders than males with ADHD, but they had higher rates of major depressive disorder and anxiety disorders when compared to males. There was a very high rate of agoraphobia and social phobia in this population. So again, the trend of seeing more anxiety, more social problems in females with ADHD than in males with ADHD. In this graph, you can see the comparison. The comparison group in blue are individuals who do not have ADHD. And the yellow is showing those with ADHD. So in this first graph, MDD is major depressive disorder. We see a much higher rate of major depressive disorder in females with ADHD than in those who do not have ADHD, approaching 20% likelihood of major depressive disorder in this study. They had higher rates of bipolar disorder. So in the general population, we were seeing just about 2% of the population, and in those with ADHD, around 5% had bipolar disorder. Anxiety disorders, very common in the typical population. In this study, those without ADHD had what is probably the average rate of anxiety, about 20% of the population. But those with ADHD were at 45% reporting anxiety disorders. And bulimia, about 3 times as great in the ADHD population as opposed to those without ADHD. Henshaw and his group out on the West Coast did another longitudinal study looking at females with ADHD. And this was published in 2012. They did not exclude common comorbidities in this study, and it was a more ethnically diverse population in terms of, and also diverse in terms of income levels as opposed to the Biederman study. This study included 105 females with ADHD and 86 in the non-ADHD group. What they found is those with childhood onset ADHD showed greater symptoms of psychopathology, anxiety, depression, etc., and they had larger functional impairments. So they were less able to combat the effects of things like anxiety and depression. They were less resilient. In most domains, those with ADHD combined and those with ADHD inattentive showed little difference. However, those with ADHD combined showed higher rates of suicide attempts and self-injury than in the normal population and in those with just the inattentive type. So the poor impulse control that we see in the ADHD combined type likely has more impact on self-harm. The most consistent findings were from parental report and objective measures, not self-report. Individuals with ADHD are notoriously not very good at self-report, especially in adolescence and young adulthood. We get much better information from direct assessments and from parents, caregivers, significant others. And interestingly, in this group, they saw that the academic area most impaired was math. And that probably makes sense because math is the area that one requires very focused attention and and each step builds on the next. So in this population, in this study, we're going to look at some of the findings. So the light blue group is the comparison or non-ADHD group. The yellow is the ADHD inattentive type, and the blue is the ADHD combined type. So in the first study, we are looking at conduct disorder and oppositional defiant disorder. And this is where one of the findings were that there wasn't much difference between the inattentive and combined. We are seeing slightly more conduct disorder, oppositional defiant disorder in the inattentive group, but not greatly. The big difference is in both the ADHD inattentive and combined group, we're seeing much higher rates of conduct disorder and oppositional defiant disorder than in the normal population. We see higher rates of depression or dysthymia. Dysthymia is a kind of a chronic low-level depression as opposed to a significant depressive episode, and much higher rates of depression and dysthymia in the ADHD groups, and much higher rates of anxiety than in the control groups. So these two studies by Biederman and Hinshaw really are showing higher rates of anxiety, depression, emotional behavioral disorders. So this is actually a quote from one of the studies that I think is so powerful I've included it. Understanding of outcomes of girls with ADHD in adulthood has clinical and public health implications. Clinically, such information would help in prognosis and would alert clinicians to the importance of recognizing ADHD and associated comorbid disorders in girls for treatment planning and early intervention strategies. From a public health perspective, the ability to predict the outcome of ADHD in girls would help focus limited resources on those individuals who are at higher risk for persistent illness with complicated outcomes. One example I frequently think of is cigarette smoking. If we think of the millions of dollars spent on public education campaigns, and then we think about how we could impact a very targeted group, such as identifying those with ADHD who are at risk of smoking early, then we might have a more significant impact than massive public health campaigns. So to date, there is not evidence-based treatment for females with ADHD. In other words, there has not been any long-term study looking at treatment of ADHD in females specifically. But the following are recommended. Oh, sorry, I'm going to move ahead because this is out of order. So first of all, treatment of ADHD starts with diagnosis. Diagnosis of ADHD should not be a yes/no question. It should be, is there ADHD and what else is there? We should start with the diagnosis of what is the nature of the person's difficulties and consider the possibility of comorbid conditions. Treatment of ADHD, the second prong of treatment is education of the patient and the significant others regarding the diagnosis. And some key points I would make here. ADHD is not an excuse. It's an explanation, and it helps to explain why behaviors are repetitive and do not change quickly. So why does punishment not result in behavior change quickly? Why does correcting a spelling word once not result in them knowing how to spell it the next time? A diagnosis of ADHD helps those who are close to the individual recognize that the behaviors are not personalized. So many times when I see families, the parents, very often the mother, feels that the child's behavior is really personalized towards them, that they throw tantrums in their presence, that they don't mind them, and the parents personalize it. And when they start to understand what ADHD is, they can start to not be as emotionally drawn into those behaviors and start to stand back and deal with them more objectively. And a diagnosis of ADHD helps those close to the individual with ADHD know how to support them. So treatment of ADHD includes diagnosis, parent and patient education regarding ADHD, consideration of medication, and the provision of external supports, psychotherapy, ADHD coaching to address ADHD and related disorders. So I am going to go back a couple of slides to a questionnaire, a self-test that was developed by Catherine Nadeau, who was an early advocate of understanding females with ADHD. And she developed this self-test for girls. Now, it's not standardized, and it's really to be completed by the child, the girl, the teenager herself. But I think that these questions emphasize how females with ADHD tend to internalize their symptoms. So the questions are, I often want to cry. I get a lot of stomach aches or headaches. I worry a lot. I feel sad, and sometimes I don't even know why. I dread being called on by the teacher because I often haven't been listening carefully. I feel embarrassed in class when I don't know what the teacher told us to do. Even when I have something to say, I don't raise my hand and volunteer in class. Sometimes other girls don't like me and I don't know why. I have arguments with my friends. When I want to join a group of girls, I don't know how to approach them or what to say. I often feel left out. I get my feelings hurt more than most girls do. My feelings change a lot. I get upset and angry more than other girls. So I'm going to skip ahead back to where I was. So given all of that, your particular parents are probably saying, so where's the hope? Well, first of all, I want to assure you that diagnosis and treatment helps level the playing field. It helps give the individual with ADHD as well as the families some knowledge of how to intervene. And we do know that diagnosis and treatment includes medication, but is not only use of medication, can help level the playing field. Parental and educator understanding helps us know how to intervene. And one of the reasons that we at CRG feel so strongly about educating people about ADHD and how it impacts others is that we think we can help people to understand and know how to support individuals with this condition. Parental understanding helps us to anticipate needs for change in parenting with each developmental level. So parenting a girl with ADHD in elementary school needs to change when they start to enter puberty and adolescence. We know that they're more likely to take risks. They're more likely to do the things that we really don't want them to do. So we have to be prepared, have a plan, talk to the young person about these issues. With a diagnosis, we have increased awareness of the hereditary nature, and that helps us identify others in the family who may need support. And we can also recognize an individual with ADHD. We can recognize their strengths and assets and focus on those as we support the needs. Many times females with ADHD are very artistic or very athletic or very musical, and we need to support those interests. So now we're going to go through the top things to keep in mind about ADHD. So if you don't remember anything else about what we talked about today, these would be the 10 things I'd encourage you to think about and to help others recognize about ADHD. First, we know that poor impulse control is usually seen before attention problems. So a lot of times families or teachers say, I don't see them having trouble with paying attention. But what people are recognizing are the impulsive behaviors. And females often have impulsive emotions that the family is seeing at home before others outside the home see those. Number two, ADHD is not just an academic problem. And many students with ADHD can do well in school until the need for organization and time management outstrip their cognitive capabilities. So for a very bright student, we may not see the impact of ADHD until they're in junior high or high school or even college. Those with ADHD typically have about a 30% delay in the acquisition of independent skills and social emotional development. Thus, a 12-year-old may only be as responsible as their 9-year-old sibling. And that's part of the condition. Many studies have told us repeatedly that there is about a 30% delay in self-regulation. And that's probably why we see many of our young adults not really hitting their stride until they're 30, as opposed to 22. For individuals with ADHD, time is the enemy. If they're doing something they enjoy, there is not enough time in the world. If they're doing something they don't enjoy, they will procrastinate or just not do it. Individuals with ADHD tend to live in the moment. They have trouble looking to the future and trouble reflecting on the past. So time is part of their disorder. Individuals with ADHD have difficulty with sustaining mental effort. School, reading, writing, all of those require a lot of mental effort, and that's difficult for individuals with ADHD. Individuals with ADHD have trouble remembering to do what they need to do when they need to do it. That's what we call working memory. And again, those with ADHD live in the moment. They don't reflect on the past, remember what happened last time, or look to the future to think of the consequences of their behaviors. ADHD causes individuals to have trouble stopping a behavior in the middle of a behavior. And most of what we know about ADHD is based on research on males. But females with ADHD are just as much at risk for problems in all areas of functioning. And finally, I want to remind us all that hope starts with diagnosis. Without diagnosis, families and individuals will spend much time, energy, and money on ineffective treatment. When treatment doesn't work, blame begins. So if you start with the right diagnoses, we are much better able to target ongoing treatment and see the benefits of treatment. I have included a bibliography and some websites that I've used in developing this PowerPoint, and also that you may find interesting and helpful. With that, I'm going to open this up to questions if there are any. So if you have any questions and you want to pose those, this is the time to do it. And I'm not seeing any questions at this time. I will check under the chat feature just to make sure. No. So since there are no questions, I hope that means I've covered this topic in a way that was meaningful. It will be posted on our website and available as all of our webinars are. We will be having another webinar at the end of April, and that one will be on nonverbal learning disorders. We hope that if that's a topic of interest to you, you will consider joining. Okay, I do have one question. Is there any style of therapy better than others? Well, as I said, there's no research specifically saying what type of therapeutic intervention is recommended. I think those I work with and who I know who treat individuals do a combination of psychoeducation, helping educate the client as well as those family members or others close to the client, helping educate about the disorder, as well as using cognitive behavioral strategies, and also problem-focused therapy. A lot of times we're just dealing with what's happening right at the moment, what we need to do to intervene. There's a question about new developments in medication. So let me talk a little bit about the medications. That's certainly one of the areas where we've seen many, many changes in the past 30 years. The stimulants are still the frontline medications, but there are many stimulants available, short-acting stimulants, both amphetamines and methylphenidates, short acting mean they last 3 to 4 hours, to longer acting forms of medication lasting up to 12 hours. We have liquids, we have pills, we have capsules, we have patches. So we now have many ways that medications can be administered. And I will say that I think working closely with a physician who understands medication is very important, so that, because a lot of times we see children who've been on medication, but it hasn't been terribly helpful because they either aren't on the right medication, or it's underdosed, or the timing of it isn't coordinated with the time of day when it's needed. There's a question about developing executive functioning skills for an adult with ADHD. And boy, that's probably a whole nother seminar. Let me say that I think the best way to improve executive functioning is for an adult to build in structures and routines and supports around them. And if an adult really wants to develop those approaches for themselves, I'd encourage them to work with an ADHD coach, because I think they are very good at helping tailor strategies for the individual based on the individual's life circumstances, schedules, and needs. Within our office, Dr. David Parker is an ADHD coach. There are certainly others, and I would just encourage adults that may be something they want to add to their treatment plan. Other than medication, what do you suggest? Well, I think the best thing I can suggest for children and adolescents and young adults with ADHD is that they have families who don't give up on them, who support them and love them, and over time, with a sense of humor, can help to put some of the quote problems into perspective. So, for example, when I'm seeing families and the parents are saying, "My child always lies," and I go, "Oh, you mean like they brush their teeth?" I mean, if we really think about it, we want our kids to brush our teeth, but it's not a life-threatening event. So I think love and support is critical for children, adolescents, as well as adults. Let's see if we have any more. Advances in integrative medicine. I'm not sure I'm the best person to respond to that, so I'm going to go on past that. How does puberty affect ADHD symptoms? Well, I think certainly puberty can affect lots of our neurotransmitters, including the dopamine. But I think probably with ADHD, one of the dilemmas we have is the external symptoms of ADHD often become less apparent. We're seeing less hyperactivity, but we are seeing an increase in difficulty with executive functioning and self-regulation in ways other than the hyperactivity. So I think people will often underestimate the impact of ADHD as a child goes through puberty and adolescence. And I think they also will attribute the behaviors to puberty and adolescence. So I think if anything, what we see is for individuals with ADHD, the impact of ADHD is people minimize the impact of ADHD while it's still playing a very critical role. Certainly for females with ADHD, we know that we need to look at the impact of their menstrual cycle on the symptoms of ADHD and emotionality. And for females with ADHD, with puberty and adolescence, we often see an increase in anxiety and depression. Okay. There's a question about exercise and ADHD. And I think is there evidence that exercise helps? And I will tell you, I'm not sure I've read recent scientific research in this area, but certainly we encourage all of the individuals we see with ADHD to build exercise into their daily routine. If it's not part of their routine, they are not likely to get out and do it. And we know it's so critical for helping them relieve stress and to have a healthy lifestyle. One last question. Are elementary school teachers receiving more instruction on dealing with these children in the classroom? And while I would love to tell you yes, I think the answer is no. I don't know for sure, but I think that teachers are now so overwhelmed with all of the things they have to receive in service on, from bullying to the core curriculum to state standards. I don't think looking at individual differences is really a thrust right now. And I certainly don't think they probably have as good an understanding as we would like of the impact on executive functions in ADHD. I've often commented that with the whole No Child Left Behind kind of approach that we started about 10 years ago, I feel like the students I see, including those with ADHD, are being increasingly left behind. They just can't keep up with the volume of work, the complexity, and the distractions. So I think for those of you listening, we still have a lot of information to spread, and certainly ADHD is a very common condition in childhood. The good news is it is treatable, and the reason I love working with females with ADHD is we can see things improve greatly with diagnosis, education about ADHD, medication, and building in supports. I want to thank you all for joining us today, and I hope you found some of this information helpful. Feel free to share it with others, and we hope to have you back at future webinars. Thank you, and good day.